Fantastic. Look, thank you very much to everybody who's taken the time out to join us tonight. A really fantastic and interesting topic, practical genetics in primary care, from carrier screening to cancer testing. We've got one of our fantastic Rextro users here, Katrina, who's the Director and Principal Genetic Counsellor at Genomic Health. Before we jump into things, though, and I hand over to Katrina, what I'd just like to say, we're really keen to make this webinar as interactive as possible. So please, on the Zoom section, you'll see there's a section for Q&A. Please post as many questions as you're interested in during the webinar. And at the end, what we'll do is we'll come back to that and obviously answer any questions and provide further instructions around the review process. Thank you very much, Katrina.
Thank you. Hi, everyone, and thank you for joining us this evening. Thanks to Rextro and the platform, I do actually get a lot of opportunity to visit GPs in and around the Perth area. And there seems to be two main concerns that I always seem to get asked, and that's around carrier screening and cancer testing. So I just thought I would present a little bit on those two topics tonight. But before I get started on that area, I just want to introduce myself and my clinical geneticist that I work with and my practice, Genomic Health. So I'm a genetic counsellor with 25 years worth of experience. I have worked in the public area before, and I was the principal genetic counsellor at Genomic Health of WA, but I'm now into private practice. I was also part of the Mackenzie's Mission Research Program, which is Australia's largest reproductive carrier screening program. Some of you would be very familiar with that program and maybe have even contributed to the research. So this is my geneticist, my consultant geneticist that helps me, Himanshu Goel. He is an associate editor at the Journal of Paediatric and Child Health, and he's also soon to be the president of the Australian Association of Clinical Geneticists. I also work with Ruvi Samasekera. She's just stepped in, she's just finished her fellowship, so she's really excited to be working as a consultant clinical geneticist with me. Look, you may have noticed that I do call myself a comprehensive private clinical genetic practice, and I do so for three main reasons, and I thought I would just talk briefly about those reasons. So access to the genetic testing. So I don't just have access to local labs, I also have access to interstate and international world-leading laboratories, which is really important when I'm seeing patients and the level of access that they have. I work really hard behind the scenes as a genetic counsellor, making sure that I am partnering with the labs that offer the best testing for the best reason, for the best price for my patients that I see. Who we see across the lifespan, and my next slide will just talk a little bit about the areas that we can offer genetic testing and counselling in. And finally, and possibly most importantly, is the care that we provide. So a journey through us is with me. Every person that comes through here, Genomic Health gets me, the genetic counsellor, at their initial appointment. They'll see me at their appointment with the clinical geneticist. I'm also there at their results appointment, and they also get me as follow-up care if needed. So this is the 6 areas that I just like to highlight and why we are a comprehensive service. Tonight we're talking about the preconception health, but we do reproductive health, general genetic health, paediatrics, so we're paediatric genetic specialists here in WA and across Australia, adolescent, and finally adult health, which is obviously what we're talking about when we're talking about cancer genetics tonight. So a bit of an overview why genetics in general practice matters. Hopefully you all know that, and I'm not going to tell you anything new. But then we'll go into carrier screening, some cancer genetic testing, and then my role as a genetic counsellor and how I can support you, and also some specialists. But just as an overview on why it matters, rare diseases collectively are common but individually rare. So a rare disease is considered anything that happens with a frequency of less than 1 in 2,000 people affected. And it's estimated that 63,000 children in WA do have a rare disease. 50% are misdiagnosed and 50% are seeing more than 10 clinicians. And I took this data off the Rare Care Team website out of Perth Children's Hospital. This is what some people face when they do have a rare condition and they're trying to figure out what's happening for their health. And they start what we call the diagnostic odyssey. So these are the hurdles and the roadmap that someone can potentially wander around before finally, eventually coming across improved health outcomes. Because you're in primary care, you are at the start of this road, and hopefully understanding the importance of genetic in primary care can help shorten the diagnostic odyssey. We do know that someone can be on this road for more than 7 years before they get a correct diagnosis and improved health outcomes. So your part and the part that you play in patient care is crucial. This is, I came across, which I really spoke to me because it was recently in the Journal of Genetic Counselling, recent publication. I've got the journal article down there at the bottom in 2025. It was fascinating to see that we are actually on common ground when we look at genetics and genetic counselling and primary care. These are the 6 main areas that we do have in common. So you can see as a genetic counsellor, I am in preconception carrier screening and prenatal testing. We also work in the newborn screening area. We do multifactorial counselling, and polygenic risk scores are coming up and being extremely popular in current care. Genetic risk assessments, and of course we're talking about cancer assessments tonight, psychosocial support and counselling, and psychiatric genetic counselling and pharmacogenomics are all areas that genetic counselling and genetic testing is embedded in. So let's just jump to a little bit more about genetic carrier screening. So why does it matter? Really, it matters because there is a huge growing demand for testing, and my practice is starting to see a real increase in the demand and patient awareness, and also with awareness does come confusion. So a lot of patients do contact me just because they're confused and they don't want to use Dr. Google anymore, which is fantastic, and it's hugely relevant in primary and specialist practice, the genetics up and coming. So hopefully these 3 points that are on the screen at the moment you all know about, and it's nothing new. So we know that carrier screening is now recommended as part of routine preconception care, and that all couples at increased chance of passing on a serious life-limiting, life-altering genetic condition such as CF and spinal muscular atrophy and Fragile X are all recommended and all offered genetic testing, carrier screening. My governing body, the Human Genetic Society of Australasia does support population-based screening, regardless of ethnicity, family history, the length of trying to conceive, and any miscarriage history that a woman may have. I've highlighted these points here because I did see not so long ago on an IVF company website that those were the reasons to consider genetic carrier testing, and that is incorrect information. We know that it supports best practice and it speaks to patient-centred care and aligns with the national standards, and that does promote safer and more informed reproductive health care outcomes for patients and in general practice. So some of the myths and misunderstandings that people may have around genetic carrier screening, we know that if you were to use family history as an indicator alone, that you would be missing possibly around about 80% of couples that might be at increased chance. So it needs to be offered to all prospective parents, not those with known risk factors. And we know, thanks to Mackenzie's mission and the data that came out of that carrier screening program, that 1 in 20 individuals are carriers for at least one recessive condition. And when I'm seeing my patients, I do let them know that being a carrier is not unusual, between 1, 5, and some people are even carriers of 8 genetic conditions. When we do look at carrier screening, we know that 1 in 240 couples might be at increased chance of having an affected child. So approximately 2% of couples, when they are screened as a couple, a carrier couple, will have an increased chance of having a child with a genetic condition. The benefits to patients and to GPs of when we do this, it's about informed choice. So carrier screening really is about choice. And as I sit here as a genetic counsellor, for me, it's about giving choice to a couple, whether they have the testing and whether they decline the testing. So even if a couple comes to see me, my main goal and main aim is not to give them a genetic test, but to make sure that they are completely informed of all their choices. Because once we do this testing and we do identify increase chance couples, the choices that are open to them are vast. Number one, they can get pregnant naturally and do nothing. They can get pregnant and choose to test the pregnancy. They may choose to terminate or continue that pregnancy. They then may also opt to do IVF and test those embryos. They may also choose to do donor egg, donor sperm, donor embryos, and also adoption is open to some of these couples. So that you can see really carrier screening is about choice and giving couples maximum choice. For some people, it's about risk management. It's not always about termination of pregnancy. It's really important for some couples to be aware, are they carrying an increased risk pregnancy? Do they need extra care? Do they need extra scans? Do they need to be delivering at a tertiary care hospital? And we know for some genetic conditions, early intervention is crucial. And yes, for some couples, it will be about prevention. We know that healthcare providers are struggling with carrier screening, and the 3-gene screen, honestly, they're some of the 3 hardest genetic conditions to understand and to wrap your head around. With cystic fibrosis, there's over 2,000 variants in that one single gene alone, and that heterozygous phenotypes are really, really important to understand and convey to couples that CF can be mild, moderate, and severe phenotype. So it's not just the classic type that we've generally grown up to understand. It's important to understand that your lab that you're using, are they screening the top 95 to 95% of carriers, which is super important. Spinal muscular atrophy, the landscape has changed drastically around this. We know that spinal muscular atrophy 2, type 2 gene does impact on SMA1. We now know that there's treatment available for children with SMA1, and all couples should be made aware that treatment is now available. And also it's important that sometimes when looking at the gene, it's a tricky gene. Sometimes we don't know whether it's in cis or trans deletion, which is really important. Then we go to my favorite, my Fragile X, and the repeat expansions that we see in that gene. It can be within the normal range, it can be in the grey zone, you can be a pre-mutation carrier, and it can be expanded. We also know that AGG interrupts are really important. So a laboratory that is reporting the AGG interrupts is really crucial to my counselling. And also, is there an additional cost if it's not reported? It means that there is potentially an additional cost to some patients. So it's important that the lab that you use is reporting AGG interrupts. We know that maternal age is important, the premutation phenotype, that females need to know that there's a potential phenotype that goes with being a premutation carrier. And there's new evidence emerging that fragment length between the AGG interrupts is also super important for counselling. So, the talking points that you might like to raise with your patients and how to integrate it into your everyday practice. You need to share the facts that we know that 80% of couples, you just can't rely on family history alone. We know it's a complex area and that you would potentially, as a GP, appreciate the input of a specialist, because we need to consider your personal beliefs and the values and experience with genetic conditions, the ethnic and cultural background of some of the patients that you're seeing, whether there's consanguinity in the family. What is the family history? As a genetic counsellor, I take a 3-generation family tree, which is really important. And we do need to talk about some genes on the carrier panels that do have implications for carrier females. And also there's issues around consent and also the limitation of the testing. Couples need to know it's a low risk, not a zero risk situation. So I thought I would just maybe share a quick case study with you, a cystic fibrosis case study that hopefully highlights some of the complexities around what seems to be a fairly straightforward situation. So I was referred this couple from a fertility clinic. The gentleman had congenital absence of the vas deferens, which was just recently discovered over the past few weeks, and based on the fact that there was azoospermia detected. As a couple, they'd been trying to conceive for about 18 months. And when he presented to his fertility clinic and this was discovered, he said, "Oh, yeah, that's right. I'm actually a CF carrier." So luckily, the specialist, the fertility specialist, zipped off a quick referral to me. So I met with this couple and explored what had happened to them and their journey so far. So he had detailed that he had asthma and been diagnosed with asthma as a child, but recently, sort of early last year, he had been diagnosed with a chronic cough that he was unable to resolve with antibiotics. And interestingly enough, he'd seen a lung physio and had mentioned that he was a CF carrier, but this wasn't taken into consideration. He remembers being told he was a CF carrier, but he's not sure where his results are, why he was designated a carrier, and what the circumstances around his testing were. So there was no records available because of some 30 years ago that testing was undertaken. I had a feeling that was probably part of the newborn screening, that potentially he'd come back with an increased IRT and done a sweat test, and that had come back negative, but potentially a CF variant had been detected, but he had no record of that and he had no evidence of being a CF carrier. He'd just been told. The female partner had been offered the 3-gene screen and she had come back low risk on all three: cystic fibrosis, spinal muscular atrophy, and Fragile X. When I explored the family history with this couple, the gentleman said that his father was the carrier. He knew that much information, but there was nil else in the family history, and there was nothing on the partner's side. So interesting counselling dilemma was how to progress with this couple, and that they understood the chances of having a bub and what was actually going on. I had to let this couple know that while the 3G gene screen was a good place to start, that because there was a carrier partner, she really did need an extensive comprehensive testing, and that the screening that she had undertaken was possibly not good enough and not comprehensive enough. They'd looked at the 50 top variants in the lab that they used, had looked at the top 50 variants in the CF gene, but really what I needed to do was look more comprehensively, look at potentially the poly-T tracks, which is another complexity that comes up with cystic fibrosis, because some CF variants, along with a poly-T tract, may actually be interesting for this couple and pregnancy outcomes. So there was a missed opportunity for proper testing for her, and for him, I needed to now repeat his cystic fibrosis testing because I was unable to get hold of any records that were 30 years of age. There was an emotional burden for this couple. They were confused and they didn't know what this all meant and how to go about resolving whether they were actually at increased risk of having a bub with cystic fibrosis. And we needed to talk about the phenotype and genotype correlations once these results came back. Because she'd already accessed the 3-gene screen, she had now exhausted her Medicare funded option, and now this more comprehensive CF testing for her was now going to be out of pocket, unfortunately. So this is a CF testing pathway that I thought might interest some of you. This is accessible through the VCGS website. It's really elegant and stepping you through how to manage a couple with potentially a CF carrier. So up the top it says, does this patient have a CFTR related disease? So my answer to that is yes. Is this a carrier test? No. Is this a diagnostic test for a patient with symptoms of CF? So I would say yes to that, certainly for the gentleman. So that is a specialist referral only, and that's the Medicare item number that is associated with that pathway. And you can see the referral through a GP would attract a private fee. And then further down, is this carrier test because a reproductive partner is a carrier? So I would reply yes to that for his female partner. And then again, it's a specialist only referral. So that's certainly where genetics helps manage patients and a referral to private practice. So some of the do's and don'ts that I can give you some tips about. Don't rely on family history alone. I think I've made that fairly clear. Don't assume that everyone wants carrier screening, and also don't assume that people don't want it. Don't assume that it's always just about termination of pregnancy. Hopefully I highlighted some of the benefits of knowing whether a couple are at increased chance of having a child with a genetic condition. Don't rush it. I spend an hour to an hour and a half with my couples going through all the implications and all the consent with them. And I encourage you to book an extended consult and potentially even in your practice, start adding a consult that does say reproductive carrier screening consults so that your patients can choose an extended consult with you. Do consider some of the ethical consideration and implications, and I'm going to touch on those in just a minute. And we are tending to head away from using the word risk. We're tending to use the word chance a little bit more. We have received feedback from a lot of people and a lot of families that chance is a better word to use. And we are trying to also not use the word mutation when it comes to genetics anymore. We're tending to use the word variant or change in gene. And that actually was fed back by a lot of people undergoing genetic testing. We do need to ask country of origin, cultural background, and ethnic origin, because some of the panels that are available out there do not speak to the diverse background and population that we do have in Australia now. A lot of the panels do not include thalassemia or sickle cell, so we do need to target some of the testing more specifically to our patients. Do ask whether they've got any experience with any genetic conditions. Some people have zero, some people have friends, and they do have an understanding of what having a child with extra needs means. And some people don't have any, and that information really does colour whether someone is going to uptake carrier screening or not. Do ask about extended family history. And the medical health and well-being of other family members. So when I'm seeing couples, I do a full system analysis for the couple, but I am also interested in extended family. Can everyone see okay and hear okay from a young age? Is there any intellectual differences within the family? Is anyone physically different? And is everyone to normal stature? Anyone particularly tall or particularly short? Is there an extended history of stillbirth or miscarriages? And if there's stillbirth, are they all males? So there's lots of questions that I ask as a genetic counsellor, trying to figure out what's the best approach for some of these families. And I would encourage you to ask some of your families if they would value the input of a healthcare professional that has time and understands the intricacies of reproductive genetic carrier screening. So some of the tips, some of this you might already know, some of these points you might already know. It does need to be before pregnancy, ideally. We know that's tricky, and I don't know how you go about embedding in your practice trying to access couples before they're pregnant and while they're in the planning phase. If you can't, then certainly it needs to be early on in pregnancy when they're visiting you for their pre-pregnancy workup. But the lab does need to know that they are pregnant, and we need to put a rush on those results for you. You need to know that each lab will have their own residual risk table, and potentially you should consider learning how to calculate a residual risk for a family. Some couples are particularly risk adverse and do want to know that if there is any extra level of genetic testing that they could consider, because they need to understand it's not zero risk, it is a low risk situation or a low chance situation. We know that sometimes interpreting reports are difficult, that not all reports given out by labs are standardised. So take your time, ask questions, reach out to the lab that you are using. Here's an example of how sometimes Fragile X is reported. It can be confusing, and I have seen carrier females missed because the interpretation is really tricky. Some of the ethical issues that are real and need to be considered. Informed consent needs to be taken. It's not just a checkbox. It's not just a list that you tick off. It is a conversation that's to be had with couples. And also informed decline is just as important as informed consent. They do need help with decision making. They do need to know what the what ifs and what might be involved in making those tricky decisions around pregnancy planning. I do talk about insurance to some couples. Usually it's minimal to none, but it can impact on carrier females' insurance. And also what can impact on carrier females is the possibility of manifesting some health implications. I do talk about cascade testing. I have the luxury of if I do find a carrier couple, I do have the luxury of being able to see family members and offer that cascade testing. You just need to consider whether you are able to raise that and follow that through with some families. And we do need to talk about people's views on having children with extra needs. I'll finish there with the carrier screening, but obviously if there's any questions in that area, we can get to them at the end of this. So I'm going to swap speeds now, and let's talk a little bit about cancer genetics. So the landscape in Australia, some of you would know there are traditional referral guidelines that go with cancer testing and referring into public genetics. Usually you're asked to consider the family history, the age of the person when they were diagnosed, and the type of cancer that the person has been diagnosed with. But there's now emerging evidence to suggest that if you use that limited criteria, that you will miss 50% of patients with pathogenic variants. And when you are referring into public, you are potentially facing longer wait times as a patient. You may have your referral actually rejected if that doesn't meet strict criteria guidelines, and sometimes smaller panels are chosen in public. But now with Medicare and private pathways, we're kind of turning that on its head, and we now know that referral pathways into private does create equality of access to genetic testing. We do use bigger genetic panels, and we do have access to diagnostic, predictive panels, and also screening panels, which is really important in a private pathway. And we tend to be fast adopters of technology. As I mentioned before, in my practice, I'm always looking for genetic testing that might be of value that I can offer on a clinical level, and I can adopt that fairly quickly and fairly easily if I've done my due diligence around the lab and what's available for patients. Person-centered care. So this is really important. The patient experience is really important. And I would say that anxiety and being concerned is a medically valid reason to seek medical help. Some people that get referred to me, it's just about anxiety and being super concerned about what is in their family. And I am able to see people and I'm able to address their fears and concerns through genetic testing and obviously genetic counselling. I believe that people are capable of making really good decisions for themselves and their families. I see people as extremely resourceful and resilient, and that if they have spent an hour and a half with me and also discussed the impact of genetic testing with my geneticist, and all things being equal, and we have weighed up the benefits versus the risks, then they can go ahead with genetic testing. So this is a case example that I think highlights that point beautifully. So this was a female that was at initial appointment. I met a 49-year-old Dutch South African background who was unaffected with breast cancer. She had seen her GP and raised her concerns about her family history, and the GP cleverly had done a CAN risk, which is excellent and really good to see. And they'd also done an eye prevent. Not sure if either any of you know about these risk estimate tools, but they are readily available to use as a risk estimate. So she was at near population risk when all the parameters were put into this algorithm. Over the next 5 years, she had a 1.6% chance of getting breast cancer and 2.8% over the next 10 years, but her lifetime risk was 8.5%, and in CAN risk it was 9.5. And interestingly, CAN risk does look at the chance of finding a BRCA1 and BRCA2 pathogenic variant, and that was at 3% for this woman. When I met with her and I took her family history, she detailed that she had an aunt with ovarian cancer at 40. She had an aunt with breast cancer at 41. She had a brother with testicular cancer at 47, which is interesting. It did pique my interest that maybe we were talking about Peutz-Jeghers syndrome and STK11 gene, which is also implicated with breast cancer. She had a maternal grandmother with lung cancer at 63 years of age. And unfortunately, her mother had died at childbirth due to preeclampsia. So this was the real point for this patient here. She had no mum. She said, well, we don't know whether mum would have gone on to develop a cancer or not because she's not here and I can't test her. She has 3 children and she's got grandchildren. So I was able to spend considerable amount of time talking about the psychosocial implications were discussed, her thoughts and feelings, and the mental health that she was experiencing at the time. I do always pause and like to talk about mental health, a history of depression or anxiety, before we're proceeding with any genetic testing. It's also really important that I spoke to her that it was not just about breast cancer. A lot of people are under the impression when they do breast cancer, BRCA1, BRCA2 testing, their only risk is around breast. I needed to let her know that there's also a risk around ovarian, uterine, and pancreatic, and also for men, there is an increased risk of prostate cancer. So during this session, I was weighing up with her the risk versus the benefits. So it's really important that we talked about, was this the correct time? And I do talk about timing with patients. It's not about not having the genetic test ever, but it is about making sure that this is the right time for the person to be undergoing genetic testing, because it can be life-altering information. We don't want people to have decisional regret around their testing. We talk about intrusive thoughts that may come while waiting for the genetic test, and also if you are positive, what sort of implications are there for those thoughts to arise, and also survivor guilt we usually talk about as well with surviving family members that may not be gene positive and all other family members might be gene positive. I do talk about insurance issues with people that come through for cancer testing. Really important. That landscape is rapidly evolving. And so I do give them the latest information. Luckily, health insurance is never impacted. We've got Medicare, and private health cover is never impacted. But people do need to know that it can potentially impact on life and income protection insurance. I was able to also talk about the implications for other family members if we did find a positive result. This had implications for her children and her grandchildren, and also brother and extended family members. So I was able to talk about other testing, such as proactive genetic testing that was available to her and her other family members. And then also I was able to touch on the possibility of a polygenic risk score if this did come back negative for her. But in the end, all things we weighed up, and she elected to go ahead with the 28 gene panel that was looking at not just breast and ovarian, but gynecological cancers. On those panels, the 28 gene panel, which was an extended panel. And I guess there's no surprises that, and the reason why I'm presenting this case, because we did end up finding a pathogenic change for this female. So she had a duplication at position number 45 that changed asparagine at position number 16, and it generated premature stop codon, which ended in a shortened or a truncated protein. This was pathogenic in both ClinVar and Nomad, and interestingly enough, it was an Africana Foundation mutation. So understanding someone and recording someone's ethnic background is super important from a laboratory point of view. So this woman, while I guess there was initial shock, she was eternally grateful for understanding that now she had a risk that she could understand and control and be proactive about. And she went on to have a double mastectomy. I have seen her children and done predictive testing for her children now. So traditionally, she would not have probably qualified for genetic testing because she didn't have a mother. The intervening person between her aunts and her mother wasn't available, and she was unaffected. So potentially, the chance for genetic testing may have been missed for this family, for this whole extended family, not just herself. So, how was I involved in her care going forward? So, I wrote a letter back to her GP and I included the EviQ guidelines. I don't know if any of you know about EviQ or use EviQ guidelines. It's an extremely important resource that I use a lot when it comes to cancer genetic counselling. And I detailed the guidelines and recommendations for her care going forward. I was able to provide her with a family letter that she could give back to and disseminate through all her family members. It's anonymous. We don't tell who the person is, but it just gives a means of giving the information through extended family members and cousins. that she may have back in South Africa. We talked about her children being at 50% risk, and the predictive testing was now available to her family members. And cascade testing was extremely important in South Africa. I was able to refer her to the pancreatic study, the clinical trial that's happening here in WA, which is really important because pancreatic cancer is one cancer that is extremely difficult to screen for. I gave her a referral to the cancer registry that's going to help her stay on top of her screening and be proactive in what she does and how she cares for her health going forward. And I was able to provide follow-up care. I rang her. I keep in contact with her just to see how she's going psychosocially and where her children are at with regards to testing. And I'm always available via email or phone call for all my patients. So some of the considerations around cancer testing for specialists and sometimes in general practice. Sometimes when to test and can be something that needs to consider. I do get a lot of requests from people for children. It is generally not accepted that we don't do genetic testing for children, and I do consider over 18 plus, and I do consults with children, but it becomes pretty apparent after not long that it's possibly not the right timing. What to order is always a tricky thing to consider. There's lots of panels out there. And lots of variants to consider within the genes. The lack of time that a lot of clinicians have, the lack of training, and some clinicians are concerned about the ethical and legal concerns about missing a risk or ordering the wrong genetic test. There's a huge complexity around the interpretation of some genetic cancer tests and a variant of uncertain significance. What do we do about that? And how do we counsel our patients when a VUS is discovered? There are complexities in family histories. There's missing information, there's incomplete information, and sometimes the information is all overseas and it's too difficult to get hold of. So panel selection is very important for some families where there's limited information. A lot of people want to know about who pays and the cost and access to private testing. I have access to Medicare funded testing, and I'm always completely cost transparent. Every person that gets referred through to my practice, I will spend 10 minutes just letting them know about the fees and charges. So it's really important that it is affordable. And it's one reason why I started my genetic practice is because affordability of genetic testing is definitely attainable for a lot of families. Really important that we do informed consent, and pre and post test counselling is offered to a lot of these families undergoing cancer testing. And once you find a pathogenic variant for someone, who else needs to be tested? And do you have the time and resources as a clinician to be able to make sure all families have disseminated the correct information through the family? So there was a recent publication about the challenges and the barriers to genetic testing that GPs and specialists feel are in place. And these are some of the points that were raised and considered in this journal article. So it's just basic cognitive overload that the need to recall highly specific information about testing and criteria is just too much. And it even just boils down to some logistics for some, that just even finding the right form, how to fill it in, how to order the correct blood. Is it 5 ml EDTA? Is it heparinized blood? Even those little minute logistics can be frustrating and time consuming. Some specialists and GPs just feel they lack the skill about how to talk to families around testing and how to do truly informed consent and how to raise that potentially genetic testing might be of benefit to someone. They don't know how to or where to send people and families. Are they best off sent to a public or private facility? And sometimes your consults are just too short to be able to cover all the important information. Genetics is complex. It's a rapidly evolving field of genetics. Even I sometimes find it difficult to stay on top of what's next and what can I offer and what's best practice for my patients. Interestingly, also, sometimes people are talking to me about the utility. Do ask their GPs to refer into genetics, and sometimes they say that their GP doesn't understand and that genetics does really have a low impact on care. So it's really important that I do spend a little bit of time educating my patients and some GPs as why genetics is important. First of all, for some people, it actually helps make sense of their journey and what they've been experiencing their whole life. Now they have a name and now they have an understanding of what's happening for them. You do get the support that you need, and early intervention we know is crucial for some genetic conditions, especially when it comes to children diagnosing genetic conditions in children. You get access to families and an understanding of what the journey might be like if you've just at the start of your cancer journey, reaching out to people that have travelled the same path of you is super important. And then can you get access any clinical trials, and can you access any research around that's available for your specific genetic condition? Sometimes practitioners do worry about the ethical and the legal concerns, and they worry about a missed diagnosis or giving the wrong test. Interestingly enough, this journal article talked about some of the solutions, which was giving more resources, more training, and more information to GPs and specialists. But I see that as more time, and it's time that you don't have. So I feel like there's got to be a better way. And one reason why I did open a private practice is to help get back more time, more of your time, and doing what you do best in your practice, and hopefully giving you a really easy referral path for your patients. So my role and how I support. So I very much work collaboratively with GPs and specialists. I'm involved in the whole process, but we don't manage people in the area of genetics. So we will refer back to you, and we usually include any management or specialist care that your patient does need. We don't, I just need to remind you that you don't need to be an expert in genetics if you don't want to be. But if you do, there's plenty of programs out there and resources that can help upskill you. But I would encourage you to look at partnering with someone who does specialize in the area of genetics. It's a rapidly evolving field. Accurate interpretation is really important because it improves patient outcomes. And I've already spoken about some of the medico-legal aspects that do come up for practitioners. We know that a lot of doctors don't feel adequately prepared to deliver and interpret a lot of the results, and that's where genetic counselling really can help with giving safe and accurate information. So identifying patients that may benefit and refer will hopefully decrease the amount of time and worry and concerns that you may have around doing the right things for your patient, the right testing for your patients. And I've just got this quote down the bottom that has come from the HGSA president, Mimi. She said that no family should be expected to make complex and difficult decisions about genetic testing, results, or management without timely access to expert advice. So I just want to highlight timely access because at the moment we know that public genetics around the country is at capacity, and certainly in the paediatric setting. I was speaking to someone in South Australia the other day, and waiting for a paediatric consult is up to 4 years now, and I know in WA it's somewhere around the 2-year mark. I just thought I would put up this quick QR code, so potentially I'll just pause here for a moment so that you can get out your cameras and just take a quick snapshot of that QR code, because this really gives a comprehensive overview of the red flags of why you might consider sending someone into a genetic practice, either public or private. So there's prenatal and preconception areas that we have talked about, and the link there also talks about, and there's adults with intellectual handicap and recurrent pregnancy loss or a congenital anomaly themselves. I actually saw a gentleman who had been born with Klippel-Feil, and he wanted some updated information. He hadn't been seen since he was 18. He'd come in for some more updated information. And of course, if anyone's got a personal history of cancer or cardiovascular sudden unexplained death, any of the hematological, neurological, any vision loss or hearing loss, and any skin manifestations would be a reason to refer into a public or a private genetic practice. And I just thought that QR code would be really useful for ongoing reference. So This is a little bit about how to refer. If you are interested in getting more information, I do accept e-referrals. I've got some referral pads that I can certainly get out to you if you want to connect via email or via my website. I do Australia-wide consults thanks to telehealth, and I also offer face-to-face appointments. That's my email address and my website. And that's a QR code that just takes you straight through to my website. So you can, again, I will pause there and potentially just let's end it there. But just down the bottom, you notice I am actually really interested in potentially bringing on a pediatrician or a neurologist or even a GP if you've got a passion or an interest in genetics and rare diseases. I'd love to hear from you. And I'm interested in expanding my team and getting maximum care to all my patients. So I think I'll end there. Thanks, Liam. That's a bit of a quick cook's tour, I think, of genetics, hopefully, in primary care with some
And
case examples.
fantastic. No, look, thank you very much for that, Katrina. And one of the things with obviously the online environment, you can't hear the applause, but thank you, thank you.
No
Um,
problem.
So guys, look, as you can see, really interesting area, and we can obviously see by the questions and the attendance that there was a real appetite in general practice for obviously this information. For those of you who don't know the role that Rextro plays within the industry, uh, what it's used for is that practices will typically make time available in the day for people like Katrina, but also the pharmaceutical reps, allied health professionals, and so forth to come and see you guys face to face. One of the big changes that we've put into the system recently is that you can actually set up separate times for different audiences. So you might have a time that's specifically available for pharmaceuticals, and you might do a separate time for the specialist category, such as the information that we've heard tonight. The other thing that you can set up is you can set up different types of appointments. So you can obviously do the meet and greets, the really quick introductions. But what we're doing is a lot of work with specialists to actually be able to come and work with you in a professional development environment in a face-to-face piece. So, and the big feedback that we're hearing from GPs, particularly when it comes to the CPD points around reviewing performance, measuring objectives, these are things that Katrina can come out and do an audit with your patients, and you can obviously have discussion and ask questions in a practice environment. So if that's something that a lot of you will probably be in practices that are currently using Rextro, or you may not be, ask the practice manager if you are, and if you are, you can jump on. Now, look, there's been a couple of questions that have come in. One of them that came in quite a lot and was very, very easy to answer is, will there be a recording? And yes, look, absolutely. What we'll do is after this webinar, there'll be an email that'll come out. We'll include all of Katrina's referral information along with the recording from tonight's webinar. One of the more complicated questions that came in, Katrina, if someone doesn't have a family history of cancer or anything particular, but are just curious about their genetic health, what would you suggest in that instance?
Yeah, that's a really good question because I do actually get quite a few phone calls from people just interested in what genetic testing is available. There is a genetic test called a proactive genetic test that's available that I do talk to a lot of people. So if they ring up and say, oh, look, I'm just curious, I'm getting towards, my senior years. I just want to know what to look out for or what's going to come back, increased risk for me. So I talk about a proactive approach. So there is genetic testing that we can do that looks at cancer and cardiac and some metabolic risks. And like I said, it's called a proactive. It looks about 180 genetic genes. And that is specifically tailored for someone that does not have a family history or someone what I would just call genetically curious. And some people have called them the worried well. But it's important that it is appropriate. So I don't ever test someone on a whole exome. A healthy, well person can't come through my door and say, oh, I'm really well and I just want a whole exome. I don't do that, but I am able to look at some cancer and cardiac genes if people are interested. I also have access to what's called a polygenic risk score. And that helps stratify people and their risk around some genetic conditions. And that's slowly but surely making its way into clinical practice. I'm certainly offering it. And that's available for someone who doesn't have, because if you don't have a family history, but you're still curious, you should still reach out and get in touch. And a referral for that reason is completely appropriate. And I would just talk to the patient about, whether they actually really do want the test when I go through all the ins and outs with them. So yeah, that's a possibility.
Fantastic, fantastic. Another question that's come in, why would a GP refer to private versus the public pathway?
Yes, good question. Look, we both offer a really good, excellent service. My colleagues that are in public are excellent genetic counselors, excellent clinicians. So it's not about that. Basically, the difference between the two of us is the time and the access. So a lot of people jump out of public just because they don't want to wait. So it's just access times are a lot shorter when you're coming private. So you can come and see with me within a matter of weeks, and my geneticist as well. We've got availability. So it's really timing that people just don't want to wait. They're anxious, they're worried, they're concerned. So sometimes that's a good reason to refer someone privately rather than public if the wait seems a bit unmanageable for that person. The other reason someone might want to come privately is that I do a lot of my testing on saliva. There's not much that I do on blood at the moment. There's a couple of tests that require blood, but a lot of people come private because they accessed saliva testing. They're phobic, they're needle phobic, and or for neurodivergent people and children, it's a much, much, much better option for them, much less invasive.
Fantastic, fantastic. And I think we've got time for one more question, but what we might do is after the webinar, any that we don't get to, we'll address in the email that goes out. The final question that a couple of people have asked, Katrina, if a GP is dealing with a patient that's gone to direct-to-consumer genetic testing, how do you generally manage that one?
That's a good one. I do get that one a lot. So yes, I do get calls from people that have done direct to consumer. Look, we say steer clear. If I've got an opportunity to let someone know that that's not the best pathway, I do, but it's unavoidable. So if a patient does come to you and say direct to consumer testing, look, I've got the BRCA1 or BRCA2 gene. What do I do about this? Can you send me for an MRI? First and foremost, they need to know that these direct to consumer tests are unaccredited labs. The read depth that is done is not accurate. And we know that there's information out there, and the research has done that 40% of the information that's produced by these companies is inaccurate. So a lot of the information is not worth the paper that it's written on. So if a patient was to come to me and say, look at my direct-to-consumer results, I say I can't. It just takes me too much time, and it's just too labor intensive, and it just is too expensive for me to sit there and go through every single variant that's been called. So what I generally say, if they have a real health concern, that we need to start from scratch, which is really a shame because basically they've wasted their money. I do know some people that do direct to consumer, and then they spend their money on that, and it's pretty useless information, unfortunately. And then what happens is they try to go back to the information and they're locked out. They actually have to then pay an extra $300 just to access their information. And the other thing is you don't actually know who's got access to your information once the testing, once you give your DNA to that lab, you don't know where that information has gone or going or been on sold to. So we do caution people with direct to consumer testing, but if someone's got an honest health concern, they should definitely reach out, but I would be referring in. But unfortunately, we usually have to start from scratch again. Yes, that's the best advice. Don't do it.
Fantastic. Excellent. Well, look, thank you very much for your time tonight, Katrina, and thank you to
No problem.
everybody who's been on the call. For anybody who wishes to use this as part of their self-reported CPD programs, there will be included in the email that comes out a link to a series of questions as part of the review. Essentially, once that's completed, we can obviously issue a certificate that you can use as a list of attendance. Thank you very much, and we'll see you next time.
Thank you. Good night.